Welcome to This Explainer. Instead of kicking things off with a standard, dry overview today, we're going to step straight into the operating room. Imagine a really high-stakes surgical puzzle, one that's going to test absolutely everything we know about modern oncology, anatomy, and landmark clinical guidelines. We're going to explore the A to Z of sentinel lymph node biopsy together, covering everything from the foundational science to the technical complications that really define the procedure. Okay, let's set up our clinical sandbox. Picture this. Our patient is a 54-year-old postmenopausal female. She comes in with a 2.3 centimeter suspicious mass right in the upper outer quadrant of her right breast. The pathology comes back confirming invasive ductal carcinoma, grade 2. It's ER positive, PR positive, and HER2 negative. But here's the absolutely crucial detail to keep in mind. Her physical exams and ultrasounds are completely normal. Clinically speaking, she has 0 affected lymph nodes. So she's scheduled for a lumpectomy and a sentinel lymph node biopsy. Fast forward to the actual procedure. The surgical team uses that classic dual tracer method, right? They inject technetium-99m sulfur colloid alongside isosulfan blue dye. The gamma probe starts ticking, and here is exactly what we find in the axilla. Node A is deeply blue-stained and highly radioactive, registering a massive 5,400 counts per second. Then there's node B, right next to it. No blue stain at all, but the probe reads 620 counts per second. And then we have node C. It's not blue, and honestly, it barely registers on the probe at 180 counts. But to the surgeon's expert touch, it is palpably firm and definitely abnormal. Now, the tension absolutely peaks when the frozen section on node A comes back, revealing a 2.8 millimeter macrometastasis.
So this puts us right in the middle of a massive surgical dilemma. First off, out of those 3 nodes we just looked at, which ones actually meet the rigorous surgical definition of a sentinel lymph node and absolutely must come out? And second, and this is the really big question here, since node A has a confirmed metastasis, does this patient need an immediate, full axillary dissection? To solve this, let's take a quick step back and look at the foundational science of how we even got here.
For decades, the gold standard of care was the Hallstadian radical mastectomy, combined with routine axillary dissection. The old-school belief was basically that cancer spread like a localized fire, meaning every single thing in its path had to be aggressively removed. But, as you probably know, this left thousands of patients dealing with severely disabling arm lymphedema and chronic pain. Today, modern practice relies on a highly targeted sentinel lymph node biopsy. And this is all based on the fascinating realization that lymphatic drainage isn't just random chaos. It's actually an orderly, highly sequential pathway.
I actually love using the airport security analogy because it brilliantly illustrates this pathophysiology. Think of the axillary lymphatic system like a multi-stage security terminal at a major airport. The primary tumor sends malignant cells out into the lymphatic channels, just like unvetted passengers. The sentinel lymph node acts as gate 1. It's the very first security desk. If the officer at gate 1 finds no contraband, meaning no metastasis, security clears the entire terminal. There's absolutely no reason to shut down the airport and search every subsequent gate, which completely spares the patient from a radical dissection.
Now, to understand where those rogue cells might actually travel, we have to quickly look back at human embryology. The mammary gland develops from the ectodermal milk line, and its drainage pathways naturally follow suit. The vast majority of the time, we're talking over 75%, lymph travels straight to the ipsilateral axilla via the subareolar plexus of Sappi. But occasionally, it takes alternative routes. About 20% of the time, it uses the internal mammary pathway, or even heads straight back toward the thoracic duct, which obviously totally changes where a surgeon needs to look.
When those cells do head over to the axilla, they travel through very specific surgical boundaries, known as the Berg levels. If you're looking for an anatomical anchor or a North Star in the OR, it is absolutely the pectoralis minor muscle. Level 1 is the low axilla, lying lateral and inferior to the pec minor. Level 2 is the mid-axilla, tucked directly behind that muscle. And level 3 is the high axilla, running medial and superior to the pec minor, reaching all the way up to the apex. This is the exact roadmap the surgical team is navigating in real time.
So here's the million-dollar question. How do you know exactly when to stop digging? Well, it all comes down to the single most important number in radioactive nodal mapping, 10%. This is the quantitative threshold that tells a surgical oncologist exactly what has to come out of the patient.
In the operating room, this dual tracer mapping provides a 97% identification rate. Think of it as the surgeon's definitive checklist. A node is officially a sentinel lymph node if it meets just one of 3 absolute conditions. First, it could be visually blue.
Second, it could be a hot node that hits that 10% radiation threshold we just talked about. Or third, and this is so important, regardless of what the dye or radiation says, if it feels firm, hard, or suspicious to the surgeon's touch, it has to come out. Now, what's literally mind-blowing here is how precise the mathematical staging gets once these nodes hit the pathology lab. The clinical interpretation is dictated down to fractions of a millimeter. Isolated tumor cells are tiny, 0.2 millimeters or smaller, and they are actually treated as node negative. Micrometastases range from just over 0.2 up to 2.0 millimeters. Anything larger than a 2 millimeter deposit is a macrometastasis. It's crazy to think about, but notice how these microscopic measurements literally dictate a patient's entire surgical plan. All right, armed with these rules, let's bring it all back to our clinical sandbox puzzle and actually do the math live. Step 1, we look at our hottest node, which was node A. It registered a super intense 5,400 counts per second on the probe. To find our threshold, we just apply the 10% rule. 10% of 5,400 gives us our absolute surgical cutoff, 540 counts per second. Any node in that bed hitting that number or higher is officially a sentinel node.
So let's check the rest of the surgical bed. Node B was hitting 620 counts per second. Since 620 is obviously greater than our 540 threshold, it definitively meets the 10% rule and has to come out. But what about node C? It only had 180 counts, well below the radiation threshold, and it definitely wasn't blue. But remember the human element of our criteria. It was palpably firm to the surgeon. The human touch overrules the tech here, meaning it meets the palpation rule. So, conclusion 1 to our puzzle is officially solved. Nodes A, B, and C are all sentinel lymph nodes, and every single one must be excised.
But hold on, what about our second big question? Node A had a macrometastasis. Now, historically, that meant an immediate radical dissection, period. But massive clinical trials totally shifted this paradigm. First, the NSABB B32 trial proved its sentinel node biopsy alone was perfectly safe for node-negative disease. Then came the true earthquake, the ACOSO 0011 trial. This completely revolutionized the field by showing we could omit dissection even if there were 1 or 2 positive nodes. And this was further backed up by the AMAROS trial, which showed that axillary radiotherapy provides equivalent control to dissection but with drastically lower lymphedema risks. So, let's apply those exact ZIA 011 criteria directly to our 54-year-old patient. Because she has a T1, T2 early-stage breast cancer, because she only has 1 to 2 positive sentinel lymph nodes, and because she is undergoing a lumpectomy followed by whole breast radiation therapy, conclusion 2 is a resounding omit the completion axillary dissection. Following this modern pathway yields equivalent overall survival, but completely spares this patient from the severe arm lymphedema she would have almost certainly suffered decades ago.
It's also pretty fascinating to see how different international bodies interpret these landmark references for daily practice. When you compare the ASCO guidelines with the NCCN or the UK's NICE guidelines, they actually all broadly agree on omitting the dissection for lumpectomy patients with 1 or 2 positive nodes. But you will notice some slight variations when it comes to mastectomy scenarios. Both NCCN and NICE lean more heavily into considering axillary radiation over surgery there, which just goes to show how dynamic and constantly evolving this field really is.
And if you're wondering why everyone is so obsessed with omitting this dissection, just look at the data on this slide. The lymphedema risk jumps staggeringly as your surgical depth increases. A targeted sentinel lymph node biopsy carries a really minimal 3 to 5% risk. But the absolute second you move to a completion dissection, ripping out level I and 2 nodes, that risk skyrockets to anywhere from 15 to 30%. A full radical dissection pushes it well over 35%. Imagine the impact of that. It fundamentally alters a person's mobility and quality of life forever. That right there is why targeted precision matters so much. Because you see, the axilla isn't just fat and lymph nodes. It's a literal minefield of neurovascular anatomy. Surgeons have to meticulously preserve some very key nerves. For instance, if you injure the long thoracic nerve, the patient suffers a highly disabling winging of the scapula. The thoracodorsal nerve travels right alongside its vein, and accidentally clipping it permanently weakens climbing or pulling motions. And just taking the time to preserve the tiny intercostobrachial nerves traversing that fat, that's the exact difference between a patient having a 70% chance of severe arm numbness post-op versus under 15%.
Beyond just the anatomy, there are some incredible real-world clinical pearls that can literally save you from an intraoperative disaster. Take anesthesiology, for example. They always have to watch out for the blue hives alert. Isosulfan blue dye carries about a 1% risk of hypersensitivity, and fascinatingly enough, it literally causes the pulse oximeter to falsely drop the SpO2 reading down to 85 or 90%. Another brilliant pearl is the ex vivo back table count. After excision, you measure the background axillary bed again. If that background radiation still exceeds 10% of your hottest node, guess what? You've still got a hidden hot node buried in that fat.
All of this intense 2 a.m. decision-making usually boils down to a few catchy surgical maxims that just echo through the OR, like, nerve stays, vein can go. If a surgeon is dissecting deep into the axillary fat and the structures look completely identical, giving a gentle pinch to the thoracodorsal nerve will cause the patient's latissimus dorsi back muscle to twitch. It instantly verifies the nerve so they can safely ligate the vein and proceed.
We've seen how this entire procedure evolved from some pretty brutal historical dissections to millimeter-precise mapping that spares patients immense suffering while still effectively curing their disease. But it leaves us with a really fascinating thought to close on. As surgical oncology continues its rapid evolution towards even more minimally invasive precision, what standard surgical practices of today will we look back on as overly radical just a decade from now? It's something to think about. Keep questioning, keep learning, and thank you so much for joining me for this explainer.